Hello, everyone, and welcome to our expert briefings. I'm Dr. James Beck, Chief Scientific Officer of the Parkinson's Foundation. Our expert briefing today will be focused on sleep challenges in Parkinson's disease. As you know, a good night's sleep is critical to our health and well-being. For people with Parkinson's, sleep is more important as the brain and body need more time to restore. Today, we'll learn about the common sleep challenges associated with Parkinson's disease and how those challenges can affect sleep. Importantly, we'll explore ways to get a better night's sleep while living with Parkinson's disease. But before we begin our formal briefing, let me just share a little bit about the Parkinson's Foundation. The Parkinson's Foundation is a nonprofit focused on bettering the lives of those living with Parkinson's through improving care and advancing research. Everything we do is done in close concert with our community to ensure that our actions are aligned with the needs and priorities of those living with Parkinson's disease. Today's program is just one example of how we are meeting our goals. And today's program is actually part of a broader program called PD Health at Home. The Parkinson's Foundation provides these weekly education wellness programs virtually through PD Health at Home series, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays. And as part of this series, we also have our Spanish language programming, EP Salud en Casa, which I hope I pronounced okay. So find out more and register our PD Health at Home programs by visiting the webpage on the screen when you have a chance. And what I'd like to do now is just get a chance to know who's listening today. It's always great to get a sense of who's joining us on the call today. So we're going to launch a poll. And if you're joining us Facebook Live, please respond using our comment section so we just get a sense of who's listening today. Fill in whether you're a person with Parkinson's, a spouse, a partner. Does your parent of yours have Parkinson's? Are you a healthcare professional? Perhaps you're joining us from a different perspective. Let us know by responding in this poll that we've just launched. And then we'll see where we are. And we can use this information, share with our speaker today to help provide some slight modifications to our talk today. All right, excellent. Not surprisingly, most of the people joining us today are people with Parkinson's and their care partners. This is fantastic. So we've got a lot in store for you today. And just to let you know that if we have a lot going on and you're distracted, or if you want to share it with some other folks, we're recording our expert briefing like we do all of our expert briefings. And so it'll be available online as part of our library. So if you've registered, we'll email you a link to the recording as well as other resources related to today's topic. So let's get on and meet our presenter today. I'd like to meet and introduce you to Dr. Aleks Videnovic. He's an associate professor of neurology at Harvard Medical School, chief of the Division of Sleep Medicine at the Massachusetts General Hospital, and director of the Massachusetts General Hospital Program on Sleep, Circadian Biology, and Neurodegeneration. Dr. Videnovic is also president of the International REM Behavior Disorder Study Group and co-principal investigator for the Network for Excellence in Neuroscience Clinical Trials, supported by the NIH. And he also serves on the executive steering committees of the Parkinson's Progression Markers Initiative and the Parkinson's Study Group. Dr. Videnovic, welcome, and thank you for sharing your time with us today.
Thank you very much, Dr. Beck, for this kind introduction. And hello, everyone. It is my great pleasure to present today on challenges that our patients and sometimes their spouses and bed partners have with their sleep throughout their journey with Parkinson's disease. I am especially pleased to be part of this great expert briefing series that Parkinson's Foundation has put together. The foundation has done a phenomenal job, in my opinion, as a physician and a scientist, in meeting the needs for the Parkinson's disease patient community. This is what we do. This is why we exist and go to work every day and do research. And I'm really very much appreciative being part of this effort to try to lessen the burden of this disease that we all need to live with on a daily basis. So thank you so much for joining today to learn more about sleep and Parkinson's. I will go ahead and share my slide, and we'll be on the way with my presentation. It's bigger. Terrific. I really do not have a lot of disclosures here. I have a lot of research support from the National Institutes of Health, but this is the only one disclosure where I served on a data safety monitoring committee for a clinical trial in Wilson's disease. It really does not have anything to do with the presentation that I will do today. These are going to be our learning objectives. I would like to present what are the most common sleep challenges that patients with Parkinson's disease experience. Would like to learn how we can diagnose and treat these disorders. And then another objective will certainly be to meet your needs through the Q&A session for some areas that you may find relevant are not covered in my talk. I would like to start by saying that even in the original description of a group of patients who Dr. James Parkinson described in 1817, it was evident that his astute clinical observations commented on problems with sleep that these patients have been experienced. This disease that he initially called shaking palsy, and this is here the initial description on the essay on the shaking palsy, later became to be known as Parkinson's disease when a famous French neurologist Charcot coined the name of this disease after this observer who reported it initially. However, it is important to emphasize that it hasn't been until over the past maybe 20 years that sleep disturbances have been recognized as a really one of the leading symptoms that affect quality of life in patients with Parkinson's disease, and that's why we today are having this presentation. We know that Parkinson's disease in majority is a disorder of aging, and aging represents the single most important risk factor for the development of Parkinson's disease. As we age, our sleep changes as well, and here are some changes that we can expect. All of us who are normally aging, right, and becoming older year after year, that we will invariably experience some changes in our sleep. Sleep is going to become less efficient. We may develop more arousals as the night goes by. And certainly a lot of patients may feel that one nap during the daytime may be beneficial for their functioning as they get older and older. And then the problem becomes even more challenging if one develops neurodegeneration. In this particular case, if one develops Parkinson's disease, because that process of neurodegeneration, which is in the middle of this graph here, affects these areas which we call circadian system and homeostatic drive. These are fancy terms, scientific terms for components that are necessary for normal regulation between sleep and alertness. So now on top of aging, Parkinson's disease-related changes in the brain affect further these sleep regulatory areas and therefore affect negatively this fine balance between alertness and sleep. That certainly follows the rotation of our planet. Then the picture gets even more complicated because it is not only that these intrinsic changes that are occurring within the brain affect the sleep and alertness, but there are these many other elements that are embedded in the Parkinson's disease that further affect our sleep. For example, certain medications that patients with Parkinson's disease take affect sleep and/or alertness. Motor symptoms, or for example, neuropsychiatric symptoms like emergence of hallucinations or mood and anxiety problems, especially overnight, that can emerge when one wakes up, complicate sleep and alertness further. On top of that, we cannot forget about the presence of primary sleep disorders such as sleep apnea or restless leg syndrome. I'm sure that you all heard about these disorders. And these conditions, on top of all of these other factors, can contribute to poor sleep and alertness. So in summary, this slide is to illustrate how complex are causes that may lead to disturbed sleep in a patient with Parkinson's disease. So when we think about sleep in Parkinson's disease, I like to think in two broad categories. One is problems with overnight sleep. Of course, when we go and try to sleep, and many problems can happen during night. But certainly we cannot forget about excessive daytime sleepiness. Inability to stay awake and alert during the daytime can have a substantial implications on the quality of life, on safety, cognitive functioning, and therefore we always need to think, how is it that I, as a patient with Parkinson's disease, function during the daytime as well? And between these two categories, it is safe to say that almost every patient with Parkinson's disease will experience some type of a problem to a various degree with their sleep and alertness throughout the journey of their disease. We will start with these nocturnal sleep problems and nocturnal sleep disturbances in Parkinson's disease. Patients may have emergence of their symptom of Parkinson's overnight, which certainly can cause problems with sleep. Patients may have a primary sleep disorder, such as sleep apnea, a prototype disorder of a larger group of the conditions we call sleep disorder breathing. I'm sure you've heard about REM sleep behavior disorder and restless leg syndrome. We will touch upon these overnight problems as well. And then there are many other causes that can lead to sleep disturbances in Parkinson's disease: mood symptoms, autonomic dysfunction, which can manifest as a need to get up, to urinate, an empty bladder, pain as an underappreciated symptom in Parkinson's disease, which can emerge overnight, and several other elements that we will talk about during this talk. Let's talk now about the most common sleep disturbance in patients with Parkinson's disease. That is briefly sleep fragmentation, fragmented sleep. By far the most common problem that patients with Parkinson's disease report to us when it comes to sleep. And usually when I speak with my patients with Parkinson's, they will say, "Doc, I have no problem. I fall asleep without difficulties. And then I wake up at midnight, at 2 a.m. and 3 a.m. Sometimes I'm up at 3 a.m. and cannot go back to sleep." So this is very disturbing to our patients, and causes can really be multifactorial. Causes can be rather numerous. Here, first couple symptoms listed here are symptoms well known to you. Usually tremor will disappear as we fall asleep, but in the lighter stages of sleep, or certainly when we wake up in the middle of the night, tremor can easily re-emerge. Similarly, if someone has difficulty moving due to slowness or prominent rigidity, they may affect their ability to turn in bed overnight or to get up to urinate. Sometimes patients experience this autonomic dysfunction, need to use the bathroom overnight frequently on numerous occasions. And sometimes there are primary problems that can be undiagnosed for a long time, like sleep apnea or some other sleep disorders. But as you think about your sleep, I'd like to ask yourself a question. Is my sleep consolidated at night? Am I one of these people who have fragmented sleep? And here is the nice illustration. What do I mean when I say fragmented sleep? These two graphs represent 24-hour periods for 7 days in a row of two patients with Parkinson's disease who were wearing this wrist-worn device, ActiWatch, that record rest and activity as patients go around and do their daily functions. And here on the left side, you clearly see a lot of robust activity during the daytime, but then you can clearly identify a sort of in the middle of this graph period, overnight period, where you don't see these black lines, right? That means there is no activity. And you can see that this person really has solid consolidated night, yes, with a few arousals, maybe just to turn around in bed that this wrist-worn device can pick on. However, if you look at this patient here, whose 1 week of activity is represented on this right graph, you can appreciate, yes, there is a nice activity during the daytime, but also is not as robust as the activity for the patient on the left. There are periods of complete quiescence during the daytime. And then when the nighttime comes, there are these clusters of awakening where clearly patient is really disturbed or frequently even gets out of the bed. Here, for example, on this line, prolonged several hour long activity during the nighttime, which should really not be happening. So when we talk about what can we do about this problem of sleep fragmentation, I'd like to introduce the concept of sleep hygiene, which is really important. We frequently hear that terminology. Hygiene may not be the best term, but it's a most widely used terminology. And this is something that we should all embrace when it comes to the effort to improve the quality of our sleep, whether you have Parkinson's or you have some other ailments or you are a completely healthy individual. These are some very important aspects that we like to encourage our patients. Don't do too much napping during the daytime because it's going to impact your ability to sleep at night. Save your exercises for earlier in the day. Limit your screen time at least a couple hours before bedtime to the best of your capabilities. I just had a patient who told me I wake up in the middle of the night. He was a young person. And he says, I retire to my bedroom around 9 p.m. And then me and my wife either read or do some computer work until 10 p.m. And then we turn the lights off. Well, that's going to substantially affect that person's ability to consolidate sleep, because that light that person is getting into their eyes is giving a signal to specific brain region and saying, well, it's not time to sleep yet, right? There is all this light. What's the difference than being exposed to bright light in the morning when the brain tells us it's time to get up? So please limit your screen time before bedtime. Obviously, caffeine and alcohol are really not good to be utilized in the evening hours. And there is this last tip that I like to comment. Don't drink too much water if you really have a lot of problems with the bladder control, because then you will for sure need to get up to urinate overnight. These are some other approaches that one can take for and consider for the management of sleep fragmentation. These slides are going to be available for you. I don't want to go into each of these elements of what can be done. Please review these. I would really stress the importance that medications need to be carefully reviewed by your care provider, because just by simply adjusting some of the medications, sleep fragmentation can substantially be improved. And there are these other comorbidities, especially psychiatric comorbidities, or identification or treatment of coexistent sleep disorder that need to be on a radar screen when one tries to manage this sleep fragmentation. Let me now move to another, and again, I'm moving very quickly. I'd like to save time for Q&As, and again, these slides are going to be available for your review at a convenient time. REM sleep behavior disorder is another condition. It is a sleep disorder which belongs to a group of disorders known as parasomnias. And in this condition, individuals really have very bad dreams with the negative emotional content, frequently filled with the fear or aggression. And they can act out their dreams, which means that if they are dreaming that they are being attacked by someone, they can start punching and kicking, trying to defend themselves as they are really doing in their dreams. And then you can imagine spouse who sleeps next to that person is really at the risk of being injured. Patient is at the risk of rolling out of bed and breaking bones or doing many bruises to their various body parts. So very, very important disorder to know of, and increasingly being more and more important for Parkinson's disease community every day. I will come to that in a second. This is what we really usually see. Maybe you all wonder, what happens when someone goes to the sleep lab. Well, we hook you with many different wires, and then we let you sleep. And then on our monitors, we can see how your sleep is progressing throughout the nighttime. And for example, this graph here outlines 30 seconds of a patient who is sleeping in the sleep laboratory. And I want to point out to many of these horizontal black lines that you are seeing here. These are actually vertical lines, sorry, these vertical lines that you are seeing here. And this is really indicative for us that this patient is not quiet during their REM sleep like we all normally are. When we enter REM sleep, we, as a matter of fact, become paralyzed and unable to move. However, in this condition, REM sleep behavior disorder, patients lose that paralysis as they enter their REM sleep, and then they can move, and we can capture their muscle activity on these channels that we record from your muscles as you go through sleep. That's why sleep study is really very valuable in establishing the diagnosis of REM sleep behavior disorder. This disorder is also very important because we know that individuals who only have REM sleep behavior disorder are at a very significant increased risk for developing either Parkinson's disease or dementia with Lewy body. And that risk is substantial. For example, here, if you look at this study that is here at the bottom, 12-year risk in this particular study is over 50% of patients. Newer study really point to even higher risk of developing Parkinson's disease or some other Parkinsonian condition if one has REM sleep behavior disorder. And why is that important? That is extremely important because now we understand that through this REM sleep behavior disorder, we have access to patients who are likely in the early stages of neurodegenerative process that will eventually lead to development of either Parkinson's disease or dementia with Lewy body, for example. And why is that important? It is important because we now have a window of opportunity to intervene with potential therapies that can slow the disease progression much earlier than we did that in the past. And the hope is if we intervene and implement these disease-modifying therapies in patients at early stages of neurodegeneration, we may be able to arrest that neurodegeneration in a more effective way, as opposed to waiting that someone goes through that sequence of several years or even a decade or so before they develop cardinal symptoms of Parkinson's disease and then try to treat the disease. So therefore, this is why this REM sleep behavior disorder is very important. Certainly, many patients with Parkinson's disease also have REM sleep behavior disorder as a coexistent feature, and we estimate about 50% of Parkinson's disease patients may have this REM sleep behavior disorder. In some of them, RBD may precede their Parkinson's. In some, that may not be the case. What do we need to do in terms of management of this condition? Well, first of all, we all need to ask ourselves, I had that falling out of bed episode 2 years ago. I didn't think much about it, but now my spouse is telling me that I start yelling every night. These are symptoms that can really go unappreciated and undiagnosed for many, many years, because who would think something if one has, who would think much of if someone has one bad dream or a nightmare until that becomes very, very prominent, and then one starts asking this question. It is really important that we educate our patients that they need to implement protective measures in their sleeping environment. They should need to have a lot of pillows next where they are sleeping, so to prevent hitting their forehead around the sharp edges of their nightstand, or sleep in a wider bed to minimize the chance for injuries if one hits or flail. Lower platform beds are much better because there'll be risk for injury from falling out of bed is going to be minimized. But there are also medications that can be used to manage these symptoms. And clonazepam and melatonin happen to be the two leading medicines that we prescribe to our patients who have this disorder. Moving on to another condition, restless leg syndrome. This is a very common sleep disorder in general population. It is present also in patients with Parkinson's disease. And we have patients telling us that every night when I sit down to watch my TV, I develop this uncomfortable, unpleasant sensation in my legs. Some patients are going to tell us it's like water dripping on my legs. Some patients will tell, I just need to move my legs. They are jumping around. Someone is going to say, I feel some bugs are crawling. And this is urging me to get up and start walking around the living room. And that relieves this problem. But the moment I sit back again to watch that TV or go to bed to sleep, these symptoms are back. This can be quite disabling symptom. It is important not to misdiagnose it with other symptoms that we can see in patients with Parkinson's disease that are due to PD. And for example, our patients will frequently complain of restlessness, that akathisia, if you heard that term. Sometimes patients will have emergence of rigidity as they sit down and watch TV for a longer time. And all of these unpleasant symptoms as well may be confused for symptoms of restless leg syndrome. These are some of the medication choices here. Again, good news is that restless leg syndrome responds favorably to the very same medications that we use for management of Parkinson's disease, but there are some other options as well that can be considered in more pronounced and refractory cases of restless leg syndrome. Something for you to note: if you have these difficulties, please consult with your treating physician. Now, moving on to sleep apnea. We all heard about sleep apnea. It belongs to a group of disorders which we call sleep disorder breathing. And what really usually happens there, as the patient falls asleep, these oropharyngeal tissues, including tongue, really can fall back. And if one has a really crowded oropharynx here with the large tonsils and a large uvula, these anatomical structures then overnight can really present the barrier for a normal flow of air. And that way, there can be a temporary collapse for that airflow. One can start to lack oxygen, and eventually patients start waking up, and they can wake up even 50, 60 times an hour without even recognizing that they are awakening, because these can be microarousals that last only 3 or 4 seconds or even less. Initially, we thought that sleep disorder breathing and sleep apnea was more common in patients with Parkinson's disease. Newer investigations have proven otherwise. So we believe that obstructive sleep apnea is present in patients with Parkinson's disease in the same frequency as is in patients in general population. But that still means that it's present in many patients, because sleep apnea is a condition which exists in up to 10% of general population. So if you have troubles with sleeping, if you're a snorer, if your spouse from time to time notices that you are holding your breath in the middle of the night, it is time really to consider sleep apnea as a possible explanation and treat it. And the way sleep apnea is treated, there are many treatment choices depending on severity, but the gold standard treatment is to apply the CPAP, which stands for continuous positive airway pressure. One has a mask to put on the face, and then there's a machine on the nightstand that blows air under pressure. It is not oxygen, it's just the simple air that is being blown under pressure to keep this airway here, to keep these areas in the back of your throat patent as you go through the night. EDS stands for excessive daytime sleepiness. So now we are turning to functioning during the daytime and the question of appropriate alertness. There are many causes that can contribute to excessive daytime sleepiness, similar causes that can also be relevant for overnight difficulties with sleep. Some medications have soporific properties and can make us sleepy. If one has sleep apnea or other undiagnosed primary sleep disorders due to poor nighttime sleep, one will certainly experience excessive daytime sleepiness. But certainly these areas that are important for maintaining alertness may be affected by the primary brain changes that are occurring as the result of PD progression. So that itself certainly may give rise to excessive daytime sleepiness in the PD community. And these slides were sort of misplaced here. I'm coming back, and I knew I had this slide, but here it is. This is how the management of sleep apnea usually looks like. There is this machine with this tubing that blows the air, and then the airway is nicely open. But there are some other treatments as well, like a dental appliance, even some surgical managements. Weight loss can be very effective in management of sleep apnea, especially in mild cases. Now, coming back to excessive daytime sleepiness, this is really a common problem. And this is one study that documented that up to 16% of all patients with Parkinson's disease may experience poor alertness during the daytime, in a contrast to only 1% of general population. In my experience, in my hands, this prevalence of excessive sleepiness in PD is even higher. The challenge is, though, that patients sometimes are really not aware that they are sleepy. That's why I always like to interview their loved ones, their family members who come with them, because they are one that really, in many cases, will bring the issue of excessive daytime sleepiness during the daytime. And if one is very sleepy during the daytime, we can do a lot of things, but if they are drivers at the same time and sleepy, that conversation usually becomes an unpleasant conversation, because we really need to restrict the driving among these patients who experience excessive daytime sleepiness. And why is that? Because patients who are sleepy during the daytime can have these sleep attacks. Sleep attacks or sudden onset sleep can occur within a few seconds, even without any warning sign. And this is one of the studies done by our colleagues in Germany, who surveyed over 5,000 individuals with Parkinson's disease who had driving license and were drivers at the moment of the study. And almost 10% of them experienced this sudden onset sleep at the wheel, and half of them really had no warning signs that sleep attack may happen or will happen soon. So therefore, we just really need to be super careful about sleepiness and sleepy driving. I mentioned about significance of getting history from the spouse and caregiver, and these are some other steps in the assessment of excessive daytime sleepiness among Parkinson's patients. And these are treatment options that one can try. I can't stress enough how important it is to diagnose sleep disorders and treat them accordingly, adjust medication regimens to minimize their effect on daytime sleepiness. And then there are possibilities to use some medications that can promote alertness during the daytime. And some of these medicines are listed here. This is not an exhaustive list, but these are most common used treatment choices. Now I would like to turn to a relatively newer development when we talk about sleep disturbance in Parkinson's disease and neurodegeneration in general. And this is the role that this circadian system plays in neurodegenerative disorders. At the core of this system is our internal clock that is situated very deep into the brain. This is our internal timer, and this clock that sits in the brain regulates any physiological process in our body. So how would this clock, which sits deep in the brain, know how to time us according to the daylight cycle that we operate under due to rotation of the planet Earth? Well, because it receives time cues from the entire environment. And most important time cue is light, and it's a bright light. That light hits our eyes, and eyes are directly connected to this clock, and therefore our clock is primed to know when is the time to get up, when is the time to go to bed. Physical activity, exercise, and feeding schedules and feeding time can also be significant non-photic cues for the function of our timer. So if light is so important, and these non-photic zeitgebers are important for this SEN, for this suprachiasmatic nucleus, that's what it stands for, that's the fancy term for our internal timer, then that internal timer communicates with all of the other body's organs and that translates how well we do with our daily function. It controls our physiology, it controls our behavior, blood pressure regulation, insulin secretion, immune response. All that fluctuates and has its own diurnal rhythm on the 24-hour period. We have utilized this knowledge of significance of that light for regulating our biological rhythms, and have initially done the study of a light therapy to try to ease sleep disturbance and daytime sleepiness in patients with Parkinson's disease. And only after 2 weeks of treating patients with the light therapy, we managed to improve their daytime alertness and nighttime sleep. And then we carried forward and conducted this Enlight PD trial, which utilized the same type of a therapy, light therapy, for a longer period of time. And this trial has just been recently completed. We are ready to submit this publication across 25 sites in North America. And we are very, very excited to further work on the development and promise of a light therapy, which you all know is a non-invasive, a widely available, non-pharmacological therapy, which may benefit not only with patients with Parkinson's disease and their sleep, but other symptoms of the disease, perhaps mood and anxiety and fatigue, etc. If you live in the area where we are, and even in the region, we'd be very happy to talk to you about many of sleep Parkinson's disease research studies that we have at Mass General Hospital. Many other colleagues across the nation run these centers, but since I'm running the study, I thought I'll welcome any of you who may want to learn more about it or get an advice with whom to connect in your respective regions of the country or world. I know this is a worldwide audience. Please don't hesitate to reach out to us. We are a resource for you. And finally, I think I'm doing good on time. I rushed a little bit. I am closing this really with the same slides, one of the same slides that I begin with this cartoon or a graph that really outlines how complex is to diagnose and appropriately manage disturbed sleep in Parkinson's patient. I would like to encourage you and ask you to please spend 10-15 minutes of thinking about your sleep. Talk to your loved ones, to your spouses about your sleep. And then next time when you see one of my colleagues, just talk to them about your sleep if you think there is a room for improvement. But almost all of us can work to improve the quality of their sleep. Certainly that's the case for me. So these are just some of the general concluding remarks. I already told you, think about your sleep, talk to your providers about your sleep, implement good sleep hygiene in any sleep environment. Think about, am I at risk, or do I maybe have symptoms of a primary sleep disorder that has been undiagnosed for a long time? And then consider not only medications to manage your sleep, but consider these other changes in your thought process and behavior, and certainly consider these time cues from the environment, like exercise, regular meal timing, and finally have to advocate for a light therapy, which certainly can be much better tolerated and easier to implement than taking medications to improve your sleep and alertness. So at the end of this talk, I'd really like to thank you all for joining today to learn more about what can go wrong with sleep, and more importantly, what you can do as the best advocate you are for yourself. And really appreciate the foundation and the team for their technical support for the webinar, and also foundation certainly for having me talk about this important topic to all of you. So thank you.
Thank you, Dr. Videnovic. I really appreciate your commentary on this issue. I mean, it's really important to realize how complex it is. And so I guess by way of saying that, there's probably no silver bullet with which to solve sleep issues. But it sounds like there's a bunch of little things that a person with Parkinson's can do to help address them. One of the things we're hearing from the audience is in particular about supplements. There's a lot on the market. People have access to that are over the counter. You even mentioned one of them, melatonin, which might help for people with RBD. What do you advise people about taking these supplements? I've heard conversations about magnesium, melatonin. What's your general recommendation for people with Parkinson's?
That's a frequent question that we get. And first, I would say that one needs to understand that any of these supplements that are available over the counter are really not regulated, like certain other medications, like Sinemet, for example, etc. So one needs to exercise caution which supplements to use, because for some of them, we really don't even have a good understanding what's in those supplements. Having said that, there are very safe supplements that we know can be quite helpful to manage someone's sleep. Melatonin, I think it's a prime example for that. Melatonin, we know, is a sleep hormone, especially if it's long-acting, can be both effective for managing REM sleep behavior disorder, but also fragmented sleep sometime. There are some other supplements that are available, these Tylenol PM and Benadryl, and these are just very frequently used by our patients, but I strongly discourage their use because of habit-forming properties that these medications have, and then terrible rebound if one doesn't take that medication and misses it for a couple nights. It's going to be miserable, totally miserable night. Magnesium is really safe. I think it's safe. A lot of we don't have a really well definitive studies to support the use of magnesium, but some patients swear by it. So if you feel that magnesium is helping you, there is really no harm, I think, if it's taken in a reasonable amount, and I would really not suggest against it at all. I think that we really also want to utilize the properties of regular nutrients. And for example, nutrients that have a lot of proteins in them, especially those that have amino acids that are supporting certain neurotransmitters like serotonin, etc. Taking some bananas, kiwis, for example, have a fantastic composition of the nutrients and certain amino acids that are going to be relevant for synthesis of our neurotransmitters that promote sleep. So these would be kind of supplements that I would be comfortable commenting on. There are many others, and in general, I do not recommend those to my patients.
So likewise, and I'm curious to hear how you respond about this for your patients, given the real interest in medical cannabis and those products. I mean, we as an organization have certainly put out a white paper and some guide to both people with Parkinson's as well as physicians. It's troublesome, especially for a person with Parkinson's. You're thinking about medical cannabis and its derivatives. What are your thoughts, especially around the realm of sleep?
Yes, and with the legalization of cannabis and so many products available, that's an excellent question. So I am going to share my personal view and belief, and not even belief, but the way I practice this, right? I am just a little bit older school in anything that I do. So I kind of call myself a little bit almost like a dinosaur when it comes to these innovations of any type. I would say that marijuana is now legalized in many regions. It's widely available. I think there are places that do this right, and that the amounts and the quality of the products is probably fine. So I think I would say that one needs to check their sources. I share exact same thing to my patients. When I tell them, I tell them I do not routinely prescribe, I do not routinely advise its use. Many of them go and try it and will have a couple of these gummies, and someone is going to have oil, etc. They will use it and they will say, this helps greatly. In my view, which is again very limited. This is not the view of the field. I just want to understand I'm speaking here in a foundation sponsor event. This is Videnovic's view. I think marijuana and those cannabis products, to be precise, cannabis products can be helpful for pain. I think this is a really important indication. I feel that in certain types of anxiety can help calm patients, and from that perspective may have some positive effects on sleep. So I do have a bunch of patients who really are trying this. I'm not stopping them from trying. All I ask, do it really in moderation, pick up a good reputable place, and let's monitor it. So I am happy to work with my patients who are using cannabis with all of those other precautions and disclosures I usually do.
Yeah, absolutely. I think it's really clear that it is a Wild West out there, and people need to be very careful about it. The Parkinson's Foundation has some guidelines about that, and it's really clear, as Dr. Videnovic has emphasized, work with your physician about this. This is something to let them know that you're doing, as well as let them, help them be aware of what's going on, because they're medications you take may or may not be compatible with that as part of that. It's interesting because, Dr. Videnovic, you've done such really pivotal work looking at circadian rhythms in Parkinson's disease, and I've seen work you've published before and presented that they're really depressed. The levels you see internal hormones that fluctuate, and so questions about entrainment in order to get those rhythms, as weak as they are, working properly for a person with Parkinson's. Is it important for a person to go to bed at a certain time of night? And I mean, meaning, I guess, because when we talk about that, it really relates to getting up. So is there a certain amount of time that you would recommend for doing it? Because some of us are night owls, some of us, are not. And so the bedtime itself may not be important as it is the consistency of it. What are your thoughts on that?
Yes, so thank you so much for that question. I think, making our daily lives regular and having routines in their lives, I think are highly beneficial for overall functioning, and maybe even more beneficial for individuals with neurodegenerative disease. I think that going to bed at the same time, getting up at the same time, having a structured routine during the daytime, eating meals at the same time, all of these have not been really we are just scratching the surface with our research, but these are gifts of nature that we have and can implement in their lives very relatively easily. We just need a good will and to be disciplined. And this can gives us a lot of benefits if we do it that way. I would say it is very important to recognize, am I an owl? Am I a lark? Because if I go to bed at 10 p.m., but my clock is telling me you are going to sleep at 2 a.m., it's not going to go well. But we can really recognize that. And it's a small percentage of patients. Majority of us should really do sleep hygiene, go to bed at the same time, get up at the same time, weekend day or a weekday, it's irrelevant, and aim for anywhere between 6 and 8 hours of sleep. I think below 6, it's a little bit too little. Above 8, maybe a little bit too much. But if you can just hit that 6 to 8 hour mark, I think that would be terrific. And what do we know about getting enough sleep? And why is this so important? We know that patients who have a good night of sleep, that Parkinson's symptoms can be much more manageable the day after. And we also know from the work that is done in the past that the responsiveness to our medications that we take for Parkinson's may be enhanced after a good night of sleep. And we all know this, whether we are in 20s, 30s, 50s, or 70s, whether we have diseases or not. After a poor night of sleep, really, we feel terrible. It seems to me, and it is my interpretation of this Parkinson's sleep benefit that we know for decades about, that this is just enhanced problem that patients with Parkinson's disease will suffer just because they have that disease. So their tolerance of a poor night of sleep is certainly less than one who is living without the disease.
Yeah, fantastic.
Regularity is important. Sorry.
Yeah, go ahead.
I think regularity is really important. I'm really glad you brought this up. This is something that we don't talk much, and we need to talk more and more in a broader Parkinson's community, so that we can both study it and offer easier solution to our patients.
So along those lines, some people invariably have to get up, go to the bathroom in the middle of the night. What impact, again, thinking about the regularity, you mentioned, trying to minimize, screens and things like that, turning on the bathroom light. Is that enough to throw off someone's circadian rhythm while they using the restroom? Is it, what do you recommend? Is it night lights, or what do you suggest to your patients?
That is also excellent question. Even if one turns light for 10 to 15 seconds, that automatically suppresses that melatonin, the very same sleep hormone which peaks during the nighttime. So you turn the light, melatonin automatically goes down to almost zero. Now then you turn lights off, and then melatonin will eventually go up. But it is really disrupting that rhythm. On the other hand, I think that in terms of the safety of our patients, when I talk about safety of Parkinson's patients, bathroom in the middle of the night poses the biggest challenge for safety of our patients with Parkinson's disease. So please, if you really have to use that bathroom in the middle of the night, consider maybe bedside commode. Be very careful as you use that bathroom at night. And I need to advocate for a good visibility. You may disrupt that melatonin, but if you gotta go to that bathroom, let's just make sure you see well. And if it's gonna bring melatonin down, let's find other solutions that we can find to minimize the need to use the bathroom. But this is what I would say about this question.
Got it. So so it just seems like, is it light intensity? I mean, would a nightlight help? I mean, so it's very dim. So, because I mean, my bathroom, when I turn the lights on, it's like, because I can't see very well, and so I need to I need to see what little hair I have. And I imagine it may be the same for others. So I've actually utilize a lighting strip and have it with red light. I remember my time in the Navy, we had red lights everywhere at night. And the idea, again, to help people, because you have to sleep at all times. And so was that something that could help? I mean, just again, curiosity.
Absolutely. Yes, absolutely. If the lower the intensity of the light, the better it's going to be for the disruption that you can get. That red light, as a matter of fact, should have no effect in theory, as you mentioned. So I think there are modifications that need to be done. And certainly if you can implement them, I would advocate for them. And on top of that, would emphasize the safety with these overnight visits to the bathroom.
So blue light is all the rage, and I'm sure you have some thoughts about that. People like to read. What about Kindles? In theory, it's a electronic paper, so it's not giving off light. You need light to see it. I mean, what are your thoughts about that? I imagine in order to read it, you need a light someplace, right? And so it's a catch-22. So you're not really helping yourself with a Kindle trying to read at bed, I presume.
Yeah, and I just really by any means want to say, okay, you're gonna eat your dinner and sit in the darkness until the bedtime. I mean, that may be great as a matter of fact for you, but I am not such a strict person. Turn your shade lamp, turn it off. Watch your TV, enjoy the show, but just don't be so close to the TV. It is all about where the source of the light is. What is the intensity of that source of the light, and what is the relationship with the bedtime? Really sitting at the computer as I look at my screen now, it really would not do me a good job. Although, gotta do it. Job doesn't stop at 5 p.m. unfortunately, but we should really try to minimize these screen times before bedtime.
Excellent. Again, focusing on the bedroom, which is a good place to be for sleep. Several questions have come in about the actual mechanics of it. What kind of mattress do you recommend? What kind of sheets do you recommend? Some people, reading through, they talk about kind of having like a paralysis, which I imagine they're having an off episode at the middle of the night. What are your advice to these individuals? I presume, soft, cushy mattresses are probably not the way to go.
That is a great question, right? We all do have a preferences for the mattress type. And Yeah, usually very hard to make decisions when I'm buying something. So going to the mattress store, it's usually not a good experience because it's really hard to decide, right? And that, but for Parkinson's community, here are some of the tips, especially for those individuals who are with the moderate to more advanced disease. Please do not have too soft mattresses. Make sure that you have satin or materials that are both for pajamas and for pillows and for covers that are going to allow you to slide better in the bed and that are going to allow you to much easier turns. And believe it or not, these small changes that one can implement make a big difference. And I frequently talk about well, sir, it's time to buy that silky pajama for the next birthday, right? So for your wife. So I think these are small things that can make a big difference. So this would be my advice in terms of the mattress. In the earlier stages of the disease, I just really do not think that that is becoming an issue. But later in the disease, maybe quite impactful on the nighttime sleep.
Yeah, I can imagine. And we've talked a little bit about REM behavior sleep disorder, and it was interesting. I liked the little cartoon with the spouse in the bed with a helmet on. What are some, but I don't think going to bed with a football helmet would be the way to go for the spouse. What do you recommend for those couples which have that? I mean, we've talked about some people talk about bedside rail to help them keep from falling out of the bed. It was a really good point you brought up about having beds that are lower to the ground, so if they do fall, it's not as much, and the pillows against that. But what do you recommend for the spouses? Is it they need separate beds? Is that what's really recommended,
Uh,
or is it the cow plus king type of bed?
well, I think that the king size bed definitely helps. And the bigger the bed, the better for that purpose. I think other aspect is maybe one of those long pillows. There are body pillows, long pillows. So when we are ready to go to sleep, let's just have that pillow maybe in between. Some other pillows, additional pillows, cushioning, on the back, may be useful as one swings. But you are right. At some point, patients will decide to separate, right? And they'll say, okay, I really need to go sleep in a separate bed. And I have many patients with this disorder who do that. Once we optimize them, we can reunite bed partners because sometimes we then have minor vocalizations or minor movements that usually do not present the problem. But there is some anxiety when we try to reunite them because some of the experiences can be quite traumatic. No, I don't want to scare our patient community who is listening or our audience today. This is not happening all that common that there are these such a violent episodes. This is how we educate patients about what RBD is. But RBD may also be pleasant, about some singing some pleasant songs or laughing. Not everything is such a violent and injury-prone behavior in the context of RBD.
Thank you. And one last question, because I know we're running out of time, and I appreciate your time as you have a lot of things going on. For people who have a hard time getting back to sleep, what do you recommend for them? Because they wake up, they turn that light on if they have to. How do they get back to sleep? What's the
Here,
approach?
this is the situation where really this requires conversation and a really detailed conversation. Why is it? What led to that arousal? Why is it that they cannot go back to bed? For some patients, we may even need to reduce the time in bed. Some patients may be laying in bed totally for 10 hours. That may not be healthy. We need to tell them you're going to reduce your time in bed for 8 hours. That itself can be helpful, but that particular questions that I think happen to be the last question is really going to require more detailed conversation with the treating physician so we can understand what's going on and suggest the best option.
Yeah, I totally understand. I think that makes sense, and it's a good way to leave this at, this is really a conversation not to just be had here, but with your physician, and as a way with which to arm yourself with some knowledge about what that conversation will entail, and so you can have a productive discussion with them. Dr. Videnovic, thank you very much for your time today. Greatly appreciate it. And this has been fantastic, and appreciate everyone who joined us today as part of that. I have to say, as you can appreciate, we had lots of questions come in, and if we weren't able to get to your question, I apologize. We just can't get to them all. We can reach out to my colleagues at our helpline, 1-800-4PD-INFO. You can email our helpline as well. We have a number of materials that cover sleeping at our website at parkinson.org. I encourage individuals to take a look at that as part of the process. We also let you know that research helps play a vital role in understanding Parkinson's. You can go online and find out about ways with which to volunteer and participate in research. Dr. Videnovic mentions some studies that he is running. I'm sure there are others that are maybe similar across that, and clinicaltrials.gov is a great way with which to do that. So we've finished up our expert briefing for the spring. We're going to take a little bit of hiatus over the summer and start again in September. And hopefully people will not be too apathetic to join us, but we're going to look to solve that challenge of apathy which can accompany Parkinson's disease as part of that process. Remember to register at parkinsons.org expert briefings to get the chance to get the emails when it's coming up as part of that process. And remind you again that we're here for you, not only through our website, through our helpline as part of the process. And as we conclude, just a reminder that this is the Zoom world. It'll just go to black, but what will pop up is a survey in your browser window. And so we encourage everyone to complete that survey. We'll pass on information to Dr. Videnovic to hear, give him some feedback, but also give the foundation feedback. What are we missing? What more do people want to hear about that? So please take that time to just a few minutes of giving us feedback on that webinar. So I want to thank everyone again for their time, and I look forward to talking to everyone again at their next expert briefing in September. Until then, take care.